Dr. Hart, I think we could go ahead and get started whenever you're ready.
Anytime you're ready, great.
Well, thank you everyone for being here today. Good evening to all of our friends in East Africa, and good morning/afternoon to our friends here in the US. Today, we're super excited to have Dr. Paul Hart with us today, a retired family physician currently living in Florida. Dr. Hart has been one of our most active volunteers with the Addis Clinic and with the Addis Clinic Volunteer Medical Corps, so we thank him for his service there. A brief background on Dr. Hart: he attended medical school in Memorial University in Newfoundland, Canada, and led an extremely storied medical career. He's practiced all over the world and volunteered everywhere, including in Latin America and East Africa. His accommodations and commendation list is longer than we have time to read today, but take my word for it, Dr. Hart is a very impressive man, and we're super happy to have him here today as he talks to us about antibiotics awareness. Dr. Hart, I'll pass it over to you for a brief introduction while I pull up the slideshow.
Well, first of all, thank you for the introduction. And it's been a real pleasure for me to get to know and to work with the providers in Kenya. I have learned a tremendous amount from their questions because the providers there see a large range of serious problems, plus obviously more minor. And I really enjoy trying to assist in any way I can. One brief comment: any feedback that I can get after we discuss a case, and this is not for about today, please give me, because I don't know. I'm assuming, I'm hoping that the information I give you is usable. But I practiced in the United States, where we have a lot of resources. I realize that that may not be the case for every practitioner in Kenya. And so I don't want to be providing ideas which are just not feasible. You know, I can get an MRI here in Florida very quickly. That may not be an option for many of your providers. So although I will include it for education, I also want to be practical in helping. And that actually goes, and if we can lead into today, because one area that I have been constantly made aware of is our use of antibiotics. And hopefully what we can do today is discuss the role of antibiotics and what we can do to prevent antibiotics being abused. So if we can have the first slide, and it's going to be shared 1 second.
Absolutely, and just a quick housekeeping note, Dr. Hart, before we get started. For all of our listeners today, please place all of your questions inside the Q&A box as opposed to the chat box. It'll allow Dr. Hart and the rest of the team to get to your questions a little bit quicker. And at the end of Dr. Hart's lecture, we're going to have a Q&A section at the end, followed by a couple of questions. But let's go ahead and get started.
Okay. So what I want to talk about is what is our responsibility as healthcare providers in using antibiotics. Next slide, please. Oh, should I move it along, or can you?
Sorry, I forgot how to unmute there. I'll move it along for you, Dr. Hart.
Okay, thank you so much. Okay, so what I want to do is do look at a number of things. What are the appropriate use of antibiotics? How do antibiotics become resistant? In other words, why, when we choose an antibiotic that should be effective, is it no longer effective? And why are we having problems as providers to appropriately use antibiotics? Next slide. If you look back in history, of course, antibiotics are one of the most successful forms of therapy in the history of medicine. You know, there have been many breakthroughs in medicine, but antibiotics or antimicrobials are clearly one of the most. Next. They've saved millions of lives that would have been lost because infections, and they have been a major a way of assisting and helping us currently with our practice of medicine. Next. It's interesting, if they go back into Nubia, tetracycline as an antibiotic was found in the bones back in 250 to 500 BC, which means earlier cultures years ago had some form of antibiotic therapy that they were using. And tetracycline, as you know, one of the reasons we do not use it in children is it can go into our teeth and into our bones. And that's how they found the tetracycline in these ancient bones. Next. In Jordan, they found that red soil put on skin infections was an effective treatment for some skin infection. And in China, for 3,000 years, herbal medicine has been practiced. So there's a long history predating our modern antibiotic usage. Next, please. But if we look currently, the medicines that we use as antibiotics now are often not as effective as they used to be. And as you may know, certain bacteria are resistant to antibiotics where years ago they weren't. When I started practicing medicine, we were using amoxicillin and penicillin for many more infections than we can now, because over the years, the medications have become, or the bacteria have become resistant to these medications. Let's move on, please. And what happens is once a new antibiotic is introduced and we start using it, sooner or later, we know that bacteria will become resistant to this antibiotic. Not to every antibiotics out there, and I'll touch on that in a minute, but a lot of the antibiotics which you now know about and we don't use as frequently is because the bacteria have developed a resistance. Next. And what is considered is almost a race between when do we find a new medicine and how soon the bacteria will become resistant to it. And so there's only a certain window of time, a period of time, when we can successfully use the antibiotics to treat the infections that we're worried about before suddenly they stop working. And it's not an immediate stop working, but it's over time you get resistance. And MRSA, which is methicillin-resistant Staph aureus, is one example. It used to be years ago that this was not a major problem. It has now become in the United States, and I assume in Kenya, a much more significant problem, and we are limited in our choice of antibiotics. And as these existing antibiotics start becoming less effective, we're going to be in a difficult situation until a new treatment or antibiotic is devised. Next.
Dr. Hart, just before I forgot to mention the polls to you. Whenever you're ready, I could launch the pre-quiz if you want.
Oh, please do it right now.
Wonderful. So to everyone listening right now, we're going to put a pre-lecture quiz. It's a short 5-question quiz on the screen. You just answer the questions. We'll put them up for about the next 3 to 4 minutes. And whenever everyone's done, just type in done inside the chat, please. The quiz is launching now.
I can only see 3. The other ones available to everybody else?
Yes, Dr. Hart, they just scroll down. There are 5.
Oh, okay,
there are
good.
5 questions. Yep.
Thanks, I didn't. And nobody's being graded on these questions either. It's just to let you have an idea of where we are. Oh, yeah.
All right, I see that almost the majority of people have answered. We'll go one more minute and then close the quiz.
Okay, should we go on to the next slide?
Absolutely, Dr. Hart. Do you want me to read the answers to you? Or how the
Sure.
audience responded? So I'll go ahead and read the questions one by one and let you know how the audience responded, and then you can provide some feedback. So question number one, how significant is the problem of antibiotic abuse? We had 50% response significant and 50% response very major.
And it's very major.
Thank you. Number two, viruses can be treated with antibiotics. 19% said true and 81% said false.
Viruses cannot be treated by antibiotics, and that is one of the major concerns with, and we'll get to that, with overuse of antibiotics when patients expect an antibiotic for every infection, even if the infection is caused by a virus, and the antibiotic will over time do more harm than good.
Thank you. Very good feedback. Question number three, the causes of antibiotics abuse is 17% said using the wrong medication, 11% said using combination medications, and 72% said not using antibiotics appropriately.
And it's the last, because it's the inappropriate use of antibiotics which leads to resistance by using them in cases where an antibiotic is not appropriate. And often, and this is not unique to any one part of the world, often providers choose antibiotics as a first-line therapy when it may not be appropriate to do that at all.
Thank you. And for the next one, there are multiple answers allowed. So I'll read the top two results. What percentage of antibiotic use is unnecessary or inappropriate? We had 56% say 50%, and 28% of the audience reported 33%.
70 to 90%. It's
wow,
tremendous.
That's very high.
Very, very high, and that will come up in a moment. It's an extraordinarily high number. Some people may say a little less, but it's an much greater percentage than I think a lot of folks are aware of.
Wow. And then question number five, the fact that bacteria develop resistance to a medication is normal and unexpected. 78% responded true, 22% false.
It is true. This is what the slide that is, I don't know if it's still projected on your screen. Unfortunately, as time goes on, we expect bacteria to change and be able to develop a resistance to the antibiotics we're using. And it happens over and over again.
Wonderful. And I believe that leads us to the next slide, Dr. Hart. So we'll continue.
Okay, thank you. So why do bacteria develop And what is felt is happening is that when one bacteria survives an antibiotic, in other words, the patient has pneumonia, it's a bacterial pneumonia, we give a drug. What happens is that this bacteria that survives passes that information on to other bacteria, which then multiply, and you develop a whole strain or a whole species of bacteria that are now resistant to that particular antibiotic, because the first number of bacteria some way had this change and they just moved that information on. And that, so it's, and how they neutralize the medication, we're not sure, and there'll be some information on that in a later slide. Next. It's, as I said, it's something that we expect to happen, and how quickly and to what extent resistance occurs is something that we can make a difference. We as healthcare providers can affect and change. We can keep antibiotics more effective by using them appropriately. Next slide. Look at now, how long do antibiotics work? Syphilis has been sensitive to penicillin for over 100 years. Before that, there were other treatments, but penicillin has always worked against syphilis. However, the Enterobacter became resistant not only to the original penicillin, but to the semi-synthetic penicillins, the cephalosporins, to other classes of drugs. So for whatever reason, this particular bacteria has been able to develop resistance. And even as we've developed new agents, it has developed resistance to them. So syphilis, we can still use penicillin, fortunately. We can't use the newer penicillins, the new agents for the enterobacteria. Next slide, please. This was an email that I received, and one of the prompts that led me to say, why are we giving this talk? And this came from one of the websites that I look at, and it looks at by 2015, 10 million people a year will die because we do not have medications that are going to fight the multi-drug resistant bacterial infections. And the National Institute of Health, which is a US body, just gave a grant to a professor to try and find a way of combating this. And this is a particular bacteria which can cause blood infections, urinary tract, lung infections, wounds infections, but many strains of the bacteria are now resistant. And so what this professor is being given almost $2 million is to try and identify and to stop the mechanisms that the bacteria are using to develop resistance, so we continue to use antibiotics to treat this particular bacteria for these type of infections. And this email came, I wrote this presentation a few weeks ago. This is really recent. This is not something that goes back years ago, 50 years ago when I went to medical school. And they're talking about 2050, which is not that far in the future if they're talking about, in the US, 10 million people a year dying. Next slide. We are making some progress. The process that bacteria use to share their DNA from one to the other is called conjugation. I'm not saying it right. Sorry. This information, by this mechanism, the information is passed from one bacteria to another. As they understand more about this mechanism, they are able to make inroads into stopping bacteria. So they knew about it in the 1940s, but now in London and England, they have managed to know and develop more into what is happening. And once we understand better a process, we can interrupt that process. We know where to target. Next slide. The American Centers for Disease Control said that a third to half of our antibiotic use, and I said more before, but I was wrong, I'm sorry, is unnecessary or inappropriate, which means that this is in the United States, but it's worldwide. That means 1/3 to 1.5 the times that we have written, I'm a provider as you are providers, have written antibiotics, they may not be necessary, or it may be inappropriate. If you stop to look at all the patients we see each day, and I was in a family practice, and I know that many folks here work in a busy clinic, could you imagine if half the time somebody came in and said, you should not have used an antibiotic, it was not necessary or not appropriate? That's a lot of patients. And that also gives us a lot of opportunity to affect change. Next slide. So when do we use antibiotics? One, a bacterial infection. Clearly, that is the major cause. But if a patient presents and they are clearly infected, they are septic, they've got a fever, their blood pressure is low, they're perspiring, they're weak, they may or not have diarrhea, vomiting, all the symptoms of infection, and they're very ill. In this case, even though we don't know the cause, it's appropriate to start antibiotics. This is one of the few times where we don't necessarily need to identify before we start why the person has an infection. You start antibiotics and often combination antibiotics while you are doing the testing and the investigation to try and say, what is the origin of the sepsis? What is the origin of the infection? So the two major causes or the two major indications for antibiotic use, clearly bacterial infection. Somebody cuts themselves, they're out working in the fields, they're working in an industry, and all of a sudden they develop an infection, they come in to see you. That's, if it's a bacterial infection, that is one of the indications. The second is sepsis. The third is some patients who have joints replaced before they have a procedure need to go on antibiotics because you're worried about blood streams will influence the, it will take that potential infection, say a dental infection, if they're working, bacteria go into the bloodstream and they could affect an implanted artificial hip, for example, or knee. Those are the only major indications. So what can you and I do as providers? Next slide. Next.
Dr. Hart, I think this is actually the last
That's it.
slide.
Okay. The question that I wanted to ask, and I know this part has been short, but this is where I want input, please. What do you as providers in Kenya think you can do to make a difference? How can you approach your patients in a way that uses antibiotics appropriately and still helps your patient? So there's one question here I see. Okay. Before we get to that, if I might, before we get to a specific indication, might I ask people to put in the Q&A, how do they think that they would approach? You have a patient come in, and let's make up a patient. This is a patient who comes in with a fever, a cough. They've been sick for 3 or 4 days, and they're coughing up some clear sputum, just whitish sputum, and you listen to them, and there's a few rhonchi in their lung fields, doesn't sound like a pneumonia. How would you treat that patient appropriately, and what would you do to decide whether or not you should put that patient on antibiotics? This is not a patient who's septic in the sense of very ill, but it is a common patient that would present here in the United States day in and day out. How would you treat that patient? If I could ask you, I guess you just either raise your hand and or how do we do this? Because I'd like to hear, can we hear voice answers? or should we do it for the Q&A, whichever you feel is better?
Absolutely, Dr. Hart. We'll allow people to raise their hands and we could just have someone answer. I already see that Vincent raised his hand, so I'll unmute Vincent if you want to answer the question. All right, Vincent, you're unmuted.
Vincent from Kenya. Hello. Hello.
Hi, Vincent, we
Hello.
hear you.
We can hear you, thank you.
Vincent from Kenya. Before we initiate an antibiotic, we should carry out some investigation to determine whether to make some diagnosis before initiating the antibiotic.
What would you do if for this patient, what investigation do you think would be the easiest for you to do there where you are in Kenya? Because I don't know the options that you have to decide whether or not an antibiotic is appropriate. What's appropriate for you and your colleagues to do?
Now, for example, the patient is presenting with the fever. Hello?
Yes.
The patient is presenting with the fever, headache, chills. The appropriate investigation we should do in Kenya, for us, we do BS for MPs, or we use MRDTs to diagnose whether it is malaria now before initiating the antibiotic. Are you getting me?
Yeah, so, oh yes, we can hear you. So you would check for malaria. If it's not malaria, assume that's, that's something, of course, here in the States we don't do, but assume it's not malaria, what would you do from there to decide about use of other antibiotics, because you're not treating malaria?
Now, okay, we just look at the signs and symptoms, then we decide whether to check for example, if the patient is presenting with itchy in the genitalia, then we carry out some investigation. Let's say VDRL. We do VDRL to determine whether the patient is present. Hello?
Yes. Oh no, we can hear you. Thank you. Okay. What we would do here in the States, and I don't know how easy is it for you to get a CBC, a complete blood count with a differential?
Differential diagnosis?
No. A white count. How easy is it for you to get a white blood cell count from a patient with a differential as to the type of white blood cells they have?
I'm not getting you.
Because the easiest way of making the determination here in the States, and I would imagine in Kenya, is if you can get a total white count and a differential of the cells. Viral infections tend to have a lower white count, bacterial a higher white count. Viral infections tend to have lymphocytes predominant versus having the neutrophils and the more, what they call a shift to the left for bacterial. That is a very good way of differentiating between a viral infection and a bacterial infection quickly. Because if it's a virus and you give an antibiotic, what happens is that patient's now got an antibiotic when they don't need it, which could give them side effects. It's not going to help their virus. And potentially, if there are other bacteria around there, they can develop resistance to this antibiotic, which is given what we don't need. So that is one easy way, if you can get a white count with a differential. And that will tell you whether or not you have a bacterial pneumonia or a viral pneumonia or a bacterial lung infection. Most cases of bronchitis, 95%, are due to viruses. In the United States, most people want an antibiotic. You're coughing, you bring up your clear sputum, you've got a fever, you expect an antibiotic. I spend more time trying to educate and tell people that antibiotics can harm them rather than help them in this particular situation. And I'm sure that in that situation, it presents for a lot of people. Also, so that's one thing you can do, is do that. Secondly, as you're investigating your patient, let's assume that they come in and they are there because they don't feel well. They've got abdominal pain, and they're retaining some fluid. Before you give them an antibiotic, you would want to do some testing. Check their urine to make sure that they don't have white blood cells. Look for kidney function. Again, do a white count. If there are no indicators that this is due to a bacterial infection, pus in the urine, pus in a wound, a white count, which is 20,000, 19,000, with the neutrophils being predominant, an antibiotic is not going to help. And many times this is where we tend to give antibiotics thinking that we're going to help. And in hindsight, we're not. We're going to develop resistance. And I don't know if anybody else there's some other questions or hands raised. Could I go back to our moderator?
Absolutely, Dr. Hart. We have a question from Anthony, our Director of Patient Care in Kenya. So I'll go ahead and unmute him as well. Anthony, you're unmuted.
Hello, Dr. Paul. Can you
Hi,
hear me?
how are you?
I'm great. Thank you for the lecture. So actually here in Kenya, the scenario that you put forward of somebody that has fevers, chills, and let's probably coughing, the complete blood count is not that hard to get, but we mostly call it full hemogram here in Kenya. So that's actually, it was somehow confusing. We call it full hemogram.
Oh, okay, a full hemogram. Thank you.
Yeah. So we use the word full. Most people are familiar with the word full hemogram rather than complete blood count, but
Thank
it's
you.
not that. And another thing is that in such instances, we even actually have gene experts.
I'm sorry,
And
I missed.
we have gene experts.
Okay. I'm
Gene
not
expert.
understanding. What is that?
Gene expert for sputum analysis.
Okay. Oh, yes, for culture, yes.
Yeah, and culture and sensitivity. So most government hospitals, referral hospitals have culture and sensitivity for the sputum.
One interesting fact about that is when you ask people to give a sputum, you're usually only getting the sputum from the upper tract. You're not really getting a deep sputum. So the value of that, at least if you're in a hospital setting, you hospitalize a patient, is somewhat limited, the ability for a patient to produce. So you may not get a really good representation. And I was taught that the only accurate way, if you really need to know what the organism is almost to do a culture directly by either putting a tube into the lungs and sampling further down, or a puncture into the lungs to sample the pus. So that's something just to keep in the back of your mind. It may not be as accurate a culture as you'd hope for. But clearly, if you can get a culture, any extra information is valuable. But if you can get the hemogram on the patient, look at it and make that decision. And what might be interesting for the people online, for the next 20 patients that you see who come in this situation where you're deciding, should I use an antibiotic or shouldn't I? Get a hemogram and see what it shows and see if that helps you with your choice. Because if it comes back with a white count of 3,000 and maybe lymphocytes, you know in your mind, most likely this is a virus. If it comes back 15,000 and neutrophils, you say, most likely this is a bacteria. And if I might ask you to keep a little record of this, a little notebook, and do 15 or 20 patients, and then let us know back here. It'd be interesting to see what your results were. And the other thing is a bad word, the other feature or factor that we have in the States, which I assume you're no different, is people expect a prescription when they go to see a doctor. To come to a doctor and be told, go home, take paracetamol and drink fluids, they don't like that answer. They want, here is your antibiotic, here's your medicine. And that, I'm sure, is a difficult, it takes a lot more time to explain to a patient, no, you're not going to get a medicine, rather than to say to a patient, sure, here's the medicine. That's the easy way out. And sometimes people are upset with, we're upset with me when I say, no, I'm not going to write you a prescription. This is a virus. I'm going to do you and other people more harm. And I don't know what the expectations are in Kenya, but I don't think your patients are any different than ours. People will expect when they go to a doctor to leave with something. Next question. Oh, there are a few.
Hart.
Oh, there are a few questions in the Q&A. The best antibiotics to treat H. pylori. Excellent question. I will send, if I can get the email for Benjamin, and I will send all this around to everybody, because there are suggestions. In the United States, they do make up a pack of antibiotic with a proton pump inhibitor, and that you give the patients a combination. But I will get you information on resistant H. pylori, because that is a major problem and is becoming a major problem. So the message on differentiating between a bacterial and viral infection, and I will then provide these, if I can get a written copy of these, in information we can send out to all of you, is looking at the white cells and the types of white cells. And those white cells that respond to a virus are one type, the lymphocytes, and those that respond to a bacteria are another type. And the problem is, and is that Dennis raised, which is an excellent problem, what do you do if you can't do the basic tests? And this is where you're left really with a difficult situation. This is where you've got to use all your clinical judgment. You've got to look at your patient. You've got to see how long this illness has. How easily can the patient get back to you? If you think that this may be a virus, because you've seen similar patients that you come to you and said, I had this illness for 2 or 3 days and I got better, and you think the patient in front of you is the same, can you say to that patient, I'd like you to take paracetamol tonight and come back tomorrow, and if you're not better, come back tomorrow and then we can give you an antibiotic. Is that an option for that patient? If the patient's traveled a long way to get to you and you're saying, this is not an option, you've got to use your judgment. And it is difficult. I was faced with a similar problem in Zambia, where if you look at somebody's throat and you're trying to decide whether or not they have strep throat, some people say they can tell. You can't tell by looking at the throat, if it's red, whether it's strep or not. They were unable to do a throat culture. You know that if you have strep and don't treat it, there is an incidence of rheumatic heart disease that develops. That's why it's extremely important to treat strep throat. But if you can't tell, do you or do you not give antibiotics? It's not an easy answer. It depends on the patient, your examination, how ill they look, and how easily you can follow up. In the States, we would often do a culture and tell the patient, we will call you tomorrow. If it's positive, if it's strep, we will put you on penicillin. If it isn't strep, you're going to take your paracetamol and only come back to us if you don't get better in a few days. I don't know, and this is where I need your help from Kenya. If just like the patient with a cough, this patient with a sore throat, where you're worried about strep, which is something that you should definitely treat with penicillin, amoxicillin, your choice, and you can't do a culture, and that patient is not readily available to come back, you have to make a decision. I don't think anybody would criticize the doctor who says, I'm going to put this patient on penicillin because I'm worried about they're younger and I'm worried about them developing rheumatic fever. I think if that patient could come back to you, or if you can do a culture, sure, that's the ideal way of practicing. But we do have to, as Dennis said, be practical. And this is where this is not an open and closed. This is where we're asking people here in the States, the same lectures are going on over and over again. I worked in what was called an urgent care center. It was a step down from the emergency room. And the person who ran it kept reinforcing the fact that consider whether or not we need an antibiotic for that patient. Think about it, do the hemogram, do a culture if it's feasible. And you're going to have the same issues raised in Kenya, and you have to make your choice. But if we can cut down the inappropriate use of antibiotics 10 or 15 or 20%, we've made a major impact. Because if each of the providers who are online now do that, think of how many prescriptions we could have saved and what an impact you made. And if you mention that to your colleagues, because obviously not everybody can be on this, look at the impact that we can make by just spreading the information and changing a little bit how we practice. Get that hemogram before you start. You know, unless that patient is obviously very septic and, you know, if it's clearly bacterial, it's a different issue. Sorry to keep going on there, but you raised some really interesting questions. Are there any other questions in the people to ask questions?
Absolutely, Dr. Hart. And I've taken note of all the questions and I'll be sure to share them with you because we have a lot of really important questions.
Good.
Before we go to other questions, do you want to run through the second post-lecture quiz?
Oh, sure. Why don't we do that?
Absolutely. Sure. So everyone, we're going to have 4 questions pop up on the screen. Similar to the first ones that we did, we'll take 3 minutes to answer the questions and then Dr. Hart will give some feedback. And the poll is launching now.
How are we doing? Are we almost ready?
We're almost ready, Dr. Hart. We have over half of the people who have answered. I say we give it 30 more seconds and we'll
Perfect.
All right, Dr. Hart, it looks like most people have answered, so we'll just follow the format of the original quiz. Question number 1. The main problem we're facing with antibiotic therapy is after a new antibiotic is introduced, we have only 15 years until resistance develops. 44% of people said true and 56% of respondents said false.
We don't know how long we have. We know we have that varies from antibiotic to antibiotic. 15 years is the number I picked out. We have some period of time. So in one sense, yes, they both are true. Yes, we have a limited period of time. Is it 15 years? Is it 20 years? Is it 12? It depends on the new antibiotic. But if you look, we really have not had a new antibiotic class developed in many, many years. We've had modifications of existing drugs, but as far as a brand new antibiotic class, it hasn't come out yet. And that's what people are looking for. Next question.
Wonderful. Question number 2, some medications that used to be effective for bacterial infections are 26% of people responded needed to be used in combination with another medicine to be effective. 5% have said have to have the dose increased to maintain effectiveness. 10% responded still effective if used as the patient presents. And the majority, 57%, says are now less effective or do not work at all.
That's right, the last one. Unfortunately, we are, as far as the first question, we are now using combination antibiotics because in the past when we didn't have to now to try and become more effective for infections that are more resistant. And the final question.
And question number 3, any bacteria that survive an antibiotic treatment, 19% need combination therapy to treat, 10% is more lethal to the patient, 14% they are studied to determine why they survived, and 57% can multiply and pass on their resistance.
And that's the final question. That is, they can, and that's why it's so important that we prevent that from happening.
Wonderful. And we have one more question. During conjugation, bacteria can exchange genetic information. This is important because, and 86% of people responded, allow scientists to find ways to stop the process and reduce the spread of antimicrobial resistance.
That's right. If I look at the questions that are asked by people, one, they're excellent questions. Peterson had an excellent question. Okay, you've done your white count. You know it's viral. Do you give a antiviral drug? If there is if it is an appropriate infection, we unfortunately have limited antiviral drugs. You know, so in the majority of cases that I'm thinking of is the bronchitis, as an example, where it's a virus. No, we don't have a drug for that. We do have antiviral agents that are out there. And if you're thinking that of a condition that we do have an agent, of course, very few compared to bacteria. Now, one of the principles to consider, you want to use more than one type of antibiotic, and it's advisable. You have to look at the infection that you're dealing with and the guidelines for treating that infection. For example, somebody comes in with sepsis and they're very ill. We know that it's a range of bacteria potentially that can cause the sepsis. So we use more than one drug because we're trying to hit a wide variety of bacteria. And we use drugs from different classes because then they're less likely to develop a resistance. It's not a perfect guideline, but there are general principles. And again, I will send out more information. I'll get all these questions and I will send out through the ADDIS project, you'll get a typed answer for all of the questions with more information, much as if you had asked me a question and we've been considering a case, and I can give you references in more detail because they're excellent questions. The next question about the flu, that's so hard. People here in the States, when they get the flu, are expecting to have an antibiotic. Yes, antihistamine, yes, an NSAID, make them feel better, lower the fever. No, not erythromycin or azithromycin. No, not indicated. But that is difficult, and that's where you're going to spend your time. Now, without a prescription, one that is not here in the States, but in many countries that I've been in, Ethiopia, Cambodia, you can walk into a pharmacy and say, I want to get amoxicillin, and they'll give it to you. That is a problem, and that does cause resistance. Our role in that is education. In that case, when we, and I don't know how your clinics function, but if you have an opportunity to educate a patient, this is something you can mention to a patient, that the inappropriate use of and I don't care what the medicine, the inappropriate use of any medication is not appropriate, especially antibiotics. You know, you wouldn't take a blood pressure pills if your blood pressure was normal. Clearly, you wouldn't use an antibiotic if you don't have a bacteria. If people can see an analogy to that and understand it, when you're feeling ill, you want something to help you. And I fully understand it, and I face that every day. Okay. Do you consider an antibiotic for acute otitis? Yes, is commonly done over here in the States, and I imagine it's the same there. The other option, which some providers used to say, is you puncture the eardrum and you sample the pus, and you know, that will relieve the pressure, that will relieve the pain, and the body can handle it. And if it comes back bacterial, you can give an antibiotic. Not many people are going to puncture eardrums. If they rupture spontaneously and you have pus coming from the ear, easy to culture if you've got the facilities and come back with an antibiotic. But many providers here, yes, in that case, much like the strep throat case, where you can't get a culture or determine whether or not it's strep, will use an antibiotic because untreated bacterial otitis media can lead to serious consequences. There are a few circumstances, but if we look at all our use of antibiotics, I don't know if you look at your average day, how many cases of otitis media present versus other illnesses. So if we can focus on the places where we can really make a difference, the bronchitis, the fever with the flu, if we can focus on those and make a difference, and we use a few antibiotics for otitis or for possible strep throat, I think we're still way ahead of the game. Next, I keep going to, okay. Yes, that's the problem of chemists or of selling antibiotics without a prescription. I don't know what you can do about that. I don't know if you can educate the chemists over there. Here they lose their license if they do that. If they go into if a pharmacist gives out medicine that they're not supposed to. I'm sure it happens over here. I don't know, but it's a problem. And I wish I had a way of addressing it. Education is the best we can do to try and, if you know a pharmacist is doing it, very gently say you may be harming your patient. And I know that, I know that there are patients here in the United States who do not have health insurance and have to pay to go see the doctor. And I'm sure it's the same over there. And if they can save the money for that, they can go to a chemist and get a prescription. They try and do it. I understand the motivation. It may not be helping them. I don't know how often that solves the problem.
Well, Dr. Hart, your timing has been absolutely impeccable. We just ran into our closing time. So first of all, I'd like to thank you for all the information you've shared with us over the course of the last hour. It's been extremely enlightening. And for everyone who hasn't had their question answered, I've taken notes of all of them. I'll pass them along to Dr. Hart afterwards, and we'll make sure we respond to each of you individually with a response, hopefully in the coming days. But I'll pass it on to Megan for any closing remarks.
Oh, may I just say one thing, please? As you
Please
know,
do.
we had some lectures before. I want to start them up again. Please send us topics that you want to hear. One of the best medical missions I did was to the former Soviet Union, where the community sent us topics that they wanted. So we knew we were looking at their needs, not my perception of what is good for you. You know, let me know. And we have a whole bunch, we now have a whole list of other ADIS providers here in the United States who have volunteered to talk to you with much more expertise than I have. I'm only a family doctor, but we have specialists who will gladly lecture to you and or talk to you and present. And I think that would be really helpful. And we can coordinate that. Megan has done a wonderful job of working on this.
Thank you so much, Dr. Hart. We appreciate your kind words, and we especially appreciate your effort this afternoon or evening in Kenya. So thanks to all who joined us. We will make this recording available in the coming days. And also I put my email address in the chat. So if you have any questions that weren't answered today, please send them my way and we will have Dr. Hart get those answers to you. Additionally, we will get the answers requested earlier and sort of put those all together and send out a package to everybody who attended here today. We appreciate your participation and look forward to coming back together in the new year to join on another topic. So thank you to everybody and have a great rest of your evening or day.
Bye-bye now.
Thank you, everyone.
Bye, Dr. Hart. Thank you.
Thank you.